record. And then Amanda, I'll turn it over to you if you want to introduce yourself, and then we'll get right into your presentation. Again, just everybody, if you stay on mute, please, but if you've got questions, please go ahead, come off mute, ask them, or go ahead and put them in the chat. And Amanda, if you can't see the chat, I'll make sure to monitor that for you, and we will keep that going through.
Great, thank you so much. So thank you everybody for joining us today. I'm going to try to throw my chat over on the side here so I can keep an eye too. But my name is Amanda McNabb. I am a licensed clinical social worker with Community Crisis Intervention and Support Services through Huntsman Mental Health Institute. Big title for saying that I'm part of the crisis leadership on our community crisis services. And I'll talk a little bit more about what those services are towards the end of my presentation to give you guys some resources that are available. I do like to talk a little bit about the fact that this presentation is intended for educational purposes. Any views expressed are my own. I don't represent Huntsman Mental Health's particular views or opinions. And the information that I'm going to provide when it comes to some of the theoretical models, treatment options, and the resources are really not endorsements of the fact that these are the only ones and these are the best things out there. You know, these are options and things that are available, as well as many others. I also do want to say that suicide and PTSD, trauma, these are really hard topics to talk about. So please do feel free to step away when need to, or just kind of, take a moment to care for yourself, because it really can be difficult to review these areas when we ourselves are potentially traumatized individuals for one reason or another. So I'd like to start by just asking the question, have you ever experienced a trauma? You don't necessarily have to answer, don't worry about self-disclosure or things like that, but just for a moment, think to yourself, have I ever experienced a trauma? Reality is that almost 100% of us here today have experienced some form of trauma, one way or another. And that's because we're human beings. And as human beings, trauma is unfortunately a part of our experience. How we define that trauma may be different depending on the individuals that we have present today. But trauma itself is a deeply distressing and disturbing experience. So obviously, trauma comes in physical and emotional forms. I recently went hiking and had trauma to my knee from falling and tripping over a rock. And now I've got this big yellow, luckily it's yellow now, but this big bruise to my knee, and it's made it really difficult to walk around on. That is a physical trauma. We also have emotional trauma, and those traumas are individual. So what may be a trauma to me may not be a trauma to somebody else, to the same person sitting next to me. Traumas don't necessarily always or aren't always experienced by siblings in the same manner. Two people that have gone through the same experience may have different reactions. Traumas can fall into multiple categories. So I should be saying emotional traumas when I'm talking about trauma, but we have one-time events, and we consider them more of an acute trauma. Happened once, it affected us, but maybe we're able to move forward from that. Or maybe it's something that sticks around for a little bit. We have chronic trauma, so multiple events that have happened and have compounded over and over again to present themselves with certain symptomology. And then we have complex trauma, those long-term repetitive events that have probably compounded over and over again and maybe causing more extensive effects on somebody's ability to function. And when we talk about function, we're talking about lots of different areas within somebody's life. So it could be interpersonal relationships. It could be personal ability to take care of oneself, could be ability to function in a work setting or school setting. So function is kind of relative to the environment that that person is in. There's a lot of different ways that we can conceptualize trauma. So I do have to disclose that trauma treatment and working with individuals who have experienced those disturbing events in their lives is something that I have tried to specialize in, and something that has been a real focus of my career. Hence, I work for a crisis department. But one of the ways that I was taught to really look at trauma and kind of conceptualize what happens for people is through the adaptive information processing model. What I like to teach people is to think about trauma and our brain as a really messy room. So if anybody is kind of like me and things are just shoved into random places in their room when they're trying to clean it up, and it's disorganized and a little all over the place. Trauma can be like that in our brains. When we have a memory that or an experience, it often gets categorized and put into a little box. So if I were to say, what did you have for dinner last night? And kind of open up that box in your brain and, oh, I had mashed potatoes, gravy, and a chicken breast. Close the drawer, you're good to go. Right? With trauma memory, we're often looking at it being all over the place. It's that sock in the underwear drawer, and the sweater under the blanket, under the bed, and it's kind of nothing's been categorized and put away, which means that as we're trying to pull out different memories, things that are not supposed to be there are popping in. So one of my favorite ways of thinking about that is the old Jack in the Box. That toy that you run the little wheel around, or the little crank, and then all of a sudden, the scary clown pops out, right? Trauma memories are often that clown popping out and finding it in places where it really shouldn't be. Another way of looking at trauma and trauma memories is a string of lights. Old time Christmas lights, one light went out, then all the lights were out, right? And you had to check every single one. And as soon as you lit up the one that was broken or not functional, the whole string of lights then lights up. And so when something happens, it can light up all of those memories of past events. Trauma doesn't always mean that it's going to turn into something more clinical. All right, we can experience a trauma and not have it continue to affect us over and over and over again in our lives. When it does, we're looking at more of that DSM, Diagnostic and Statistical Manual diagnosis, as maybe acute stress disorder. So if it's something that's happened and it's within a short time frame, usually around 4 weeks, then we're seeing symptomology, we're going to tend to lean towards that acute stress disorder diagnosis. If it's lasting longer than that, then we're probably looking at our PTSD diagnosis, which is the long-term reaction, which affects emotions, memory, physical symptoms, and our relationships. The actual diagnostic criteria is pretty lengthy, but the very first one is that somebody has witnessed, either in person or really has that first person experience with a traumatic event. So something has occurred that has actually threatened an individual's life. Now, what's interesting is that there's been a lot of studies since 9/11 about the development of PTSD through witnessing something through the media. So with 9/11, we had individuals all across our nation watching live on the news the impact to the Twin Towers, right? They weren't physically present in the moment at the towers in New York, right? But they're watching this event happen and unfolding and repeatedly seeing the initial strikes. There's a lot of studies about how PTSD may have developed in individuals from that exposure and to what's going on. But oftentimes we're looking at a violent incident that has occurred. Um, and looking around kind of these different diagnostic criteria. So a stressor that has happened, are there intrusive thoughts? Is there certain behaviors that are happening which might be considered avoidant or reenactments of things? How long has it been going on? How is it impacting an individual? And what's the mood ratio or participation related to it? The intrusiveness may come as thoughts, it may come as nightmares. Lots of different potential impact, really, when we look at PTSD. And as we go on, we're going to talk a little bit about how a lot of those things also impact the idea of suicide and suicidal ideation. But before we move there, I want to take a minute to talk about the window of tolerance. And just if anybody has heard of the window of tolerance, polyvagal theory, this is kind of a different way of picturing it itself. But the idea is that as human beings, we have an area where our emotional distress is just right so that we are open to learning new things. And that's kind of our window of tolerance. And that's why it says, I'm calm enough to learn, right? If we're hyper aroused, if we're moving up, we're working towards that anxiety side of things, then we're in a situation where we're not processing new information that's going on. And when we're flustered and avoidant and kind of removing ourselves from the situation, we're also not able to process new information that's going on. When somebody has PTSD, they're often fluctuating between the two sides, and that window of tolerance can be a lot smaller for learning of new things. One of the symptoms that we see is hyperarousal or hyper anxiety, focus on everything that's potentially a threat around them. And another slide will talk a little bit about what that looks like biologically as well. We also can see people start to dissociate and disconnect from the world around them because it's really, really exhausting to be constantly on edge, looking and scanning for potential threats. So we might see the other side of things. With PTSD, we're really trying to find how can we open that window of tolerance for an individual to improve functionality, to improve their ability to engage in their support systems and the world around them. So that window of tolerance becomes a clue as to if somebody is suffering from a post-traumatic stress reaction. It's also a treatment or an intervention for somebody. I want to take another moment to identify cultural aspects and how cultural experiences, values, and beliefs might influence how somebody interprets a reaction or creates some form of reaction. So when it comes to culture, all of us have different backgrounds. All of us have different ways of looking at our world, really, to talk about it. And so are there different things within cultures that may go into experience of PTSD, diagnosis of PTSD. Theoretical question. Again, not something that I expect anybody to absolutely say yes, and here's why or how. But just take a minute and think about it in your culture, in your background. How is trauma looked at? How does trauma be stigmatized in things? How does your culture become a protective factor or maybe another factor that compounds? Or yeah, culture compounds the experience of trauma. For some, culture enhances the meaning of an individual's life and how that trauma is looked at. For others, it may influence help-seeking behaviors. We have different cultures where asking for support is taboo. We have other cultures that are very open to seeking support when something negative has occurred in their life. We have cultures that really focus on the suck it up. And we have cultures that are less so. And when we're talking about culture, we're not always talking about ethnic and racial background. So culture incorporates military or law enforcement background. It incorporates the deaf and hard of hearing subgroup, or social setting and social identifications. There are specific cultures or cultural norms within the LGBTQ plus identification and, again, kind of network of individuals. I'm trying not to use the word culture to describe culture, but in a lot of ways that's something that we need to take into account when we're looking at PTSD, into trauma, into diagnoses in general. There are certain expectations that may play a role. So I put up an example here of corporal punishment as a way of looking at how culture may impact trauma and PTSD. When I was early on in my career as a social worker, I worked in home with individuals who were at risk of losing their children to Child Protective Services or were just receiving their children back from having been removed out of the home. And one of the things that frequently came up was this concept of physical punishment and corporal punishment with individuals. In some groups, this was the norm. Kid did something wrong, you hit them with a stick, a broom, a hand, whatever it may be. In certain societies, that is an absolute no-no. That is considered physical abuse and will result in children being removed from the home. In other groups, it's well, we just don't talk about it. Parents have the right to discipline their kids whatever way it is, and so we're not going to intervene, and we just don't talk about it. Corporal punishment for some is a trauma. It's something significant and can lead to further development of symptoms later in life. For others, it's just a part of life and you keep moving. It's not to say one way or the other is correct, is appropriate, is, whatever judgment you want to place on it, right? But depending on how a culture and society looks at that action is really whether they start to fit these diagnoses that we have out there. Ultimately, a diagnosis is a way of putting something in a box and being able to say, okay, here's a general idea of how we can intervene with an individual. So really, the take-home message is we have to look at culture when we're looking at the way trauma is affecting somebody and how we create the diagnostic information and potential diagnoses around what's going on for this individual. So I did get a question about physical changes in the brain. And yes, there are actual physical changes in the brain that can happen over time. What we're seeing with individuals who are dealing with trauma and who may be working towards the development of symptomology or have developed the symptomology that would go under a PTSD diagnosis, we are seeing physical changes in the limbic system. So if you think about your brain as a little fist, right? Frontal lobe, or the neocortex, is that outer kind of frontal piece that really helps with logic, reasoning, emotional regulation, and being able to say what is socially acceptable, what is a socially acceptable way of responding to a situation. In the brain, on the inside, you've got the limbic system. So it's the part of the brain that's really based on emotional regulation itself when it comes to experiences. So, am I loved? What are my actual connections within my support group? Little bit more towards the emotional brain versus wise mind when we're looking at it from a DBT lens of things. And then your reptilian brain, or kind of the brain stem, is your automatic fight, flight, or freeze, or the kind of side of what's happening from the more automatic responses regarding breathing or blinking or things like that. When we're talking reptilian brain, we are talking our very basic responses to a stressor or a trauma. And then limbic is more the mammalian side of things, where we start looking at the emotional pieces. What we know is that these areas are impacted by cortisol levels, and cortisol is a stress hormone. So the more stressed we are, the more cortisol we have, the more adrenaline we're running on, which over time really does make changes when we're dealing with chronic stress. And chronic stress is part of post-traumatic stress disorder. These physical changes are often, well, I don't want to say that they're permanent, because they really can make changes to our brain. However, it may not ever be exactly what it used to be. We can rewrite pathways. We can rewrite the way our brain is releasing and absorbing these stress hormones. That's one of the great things about a brain. It's very, we've got brain plasticity. And so we're able to make those through a lot of different means. Some of it is chemical. So often with PTSD, you will see people who are diagnosed and put on medications because they're trying to help calm and stimulate different areas of the brain and the chemical processing that happens. Sometimes if we can intervene pretty quickly, whether it's through debriefing, therapeutic intervention, through chemical intervention, things like that, we can actually prevent some of that trauma that happens to the brain itself because of trauma we've experienced. At other times, it's going to take a lot more. It may take a combination of therapy and chemical and all of those different components in order to reactivate what we need to within the brain itself. So there's a lot of biological science behind trauma in the brain and PTSD. A lot of that research is being done through the VA, the Veterans Administration, and the VA system, because honestly, we have a lot of individuals who have experienced trauma because of the military. And we have a little, I would say, um, kind of a ready group of individuals that we can um, to study, not necessarily experiment on. It's kind of looked down upon, but to really focus in on. So I wanted to throw this one in here just as a visual of the brain changes. This is looking, oops, sorry. This is looking at a very specific reuptake of chemicals within the brain and what's active and not active. But the idea is we have a control. So somebody who really is not being looked at for major depressive disorder or PTSD and isn't identifying, experiencing any type of suicidal ideation. Somebody with a diagnosis of depression, but no suicidal ideation, somebody with depression and suicidal ideation, PTSD, no, PTSD, yes. And you can see that certain areas of the brain become more and more active, the more symptoms that they're having and the potential for that suicidal ideation. That's exhausting, really, to have your brain always active and never really at rest. And there's, again, a lot of studies on brain imaging and things like that to try to find ways to help um, kind of intervene on a chemical level, be able to target medications and things like that. But medication is not always 100% necessary. There's a lot of other ways of intervening and helping to reverse some of those changes that have happened within a brain itself. Um, and this is again somebody with more um, chronic symptomology and not necessarily within that kind of 4 weeks after a trauma has happened. But one of the things that as providers, as individuals who are interacting with others and trying to assist when somebody has experienced trauma and maybe experiencing PTSD, that we're looking for are really things that kind of go along with a lot of other mental health. So emotional dysregulation, right? That could be part of bipolar disorder, or it could be a part of depression. It's definitely a part of our post-traumatic stress disorder diagnoses. Numbing, being able to say, I just can't deal, and therefore I am walking away emotionally from what's going on. We see physical symptoms. So with PTSD, you might have somebody with chronic inflammation of the stomach, and they're dealing with what may look like Crohn's disease, or honestly, it could be Crohn's disease that's causing some of the PTSD, because Crohn's can be a very traumatic situation, or a traumatic, I don't want to say event, but experience for somebody. We may see that hyperarousal, that person always being on alert, scanning their environment for what's going on. Sleep disturbance. So maybe it's bad dreams, maybe it's a hard time falling to sleep. Um, it's staying asleep at times, maybe nightmares aren't there, but they're just waking up over and over again because, again, their body is trying to stay constantly in tune with what's going on. Might be some cognitive errors or inappropriate guilt around something. So we might refer to it as survivor's guilt, right? Idealization of others. This is what should have happened. This is, people who can deal with the trauma and deal with what's going on better than I can. And therefore they are better than me. So it starts to impact self-esteem and thoughts about self. We may see people who are dealing with hallucinations and delusions, right? Trauma, and I'm seeing out of the corner of my eye an image of a person that was connected with interpersonal trauma that may have happened. Intrusive thoughts, triggers and flashbacks. Again, when we're thinking about that messy room and things popping out of nowhere, right? They're triggers that may lead to re-experiencing the trauma that has happened. When we're talking about dissociative, we're really talking about um, disconnection from their experiences. So depersonalization may be that persistent or recurrent experiencing of feeling detached and outside of one's own body. I worked at the VA actually for a little while, and I had an individual who just being present at the VA and knowing that there were other soldiers potentially around them would trigger flashbacks to their trauma. And unfortunately for them, their trauma was related to sexual trauma. And so being around males, especially male soldiers, was really hard, but that's where they were getting their primary care. And so it was something that was constantly being re-triggered if they had to come in. Luckily, we worked in the women's clinic, and so there weren't really as many males around, and we were able to come up with some ideas and some ways of kind of helping her to feel less triggered in those situations. But depersonalization, derealization. So feeling like things are not reality, that they're in a dream. This one is often connected with blackouts or that inability to connect because of substance use. And that's something that we look for too, is the idea of increased substance use, because it may be a way of self-medicating and dealing with what's happening when they feel like they can't. Unfortunately, with substance abuse, we are also looking at a decrease in the ability to regulate our behaviors because it's impacting that frontal lobe, and it puts people at higher risk for being impulsive. So we've got somebody who may already be dealing with impulse control because of the trauma and the PTSD, and now they have substances that they're utilizing, which are also decreasing impulse control. So when we're looking at an individual for potential PTSD and symptomology, we're looking for a recognition of their fight, flight, or freeze responses. We're looking for potential reenactment. So with kids, reenactment of trauma and PTSD may be crashing things together when there's been a trauma from a car accident, or again, to use 9/11, we saw a lot of kids who were in play causing crashes and things like that because they were trying to process through what they had seen with airplanes crashing into buildings, right? Reenactment may come in the reckless driving or the unsafe behaviors related to sexual encounters or relationships, maybe getting into destructive relationships over and over again. Oftentimes people are doing this subconsciously or unconsciously and are trying to look for a way to master what happened to them, or at least master the feelings around the situation. Up right now is an example of the PCL5, which is a post-traumatic checklist that individuals would kind of rate, self-rate the experiences that they're having. And all 20 of these questions really are the different criteria for PTSD. So repeated disturbances, sudden feelings of stress, being able to say, whether I'm kind of jumpy or if I'm having that anxiety reaction without necessarily knowing what the trigger is to it. When I'm talking about the different fight, flight, or freeze reactions, when I'm talking about kind of trauma and crisis and things like that, I often talk about if a bear were to walk in the door, right? Most of us are going to have some sort of reaction to that. It's going to be momentary, it's going to be about safety, and then we're okay. With post-traumatic, that reaction is going to stick around a lot longer. The PCL5 is a validated tool that a lot of groups use for PTSD screening. And so I was initially introduced to it when I was working at the VA. And so it's one that I've presented before as an initial screener before saying, okay, does this person really meet the diagnostic criteria of what's going on? It's also a great way of just looking at, what are the potential criteria for somebody who are experiencing trauma reaction. There are other validated tools out there for sure, but this is just one that I've had some experience with that I find is pretty easy to look at. So with depression, we've got the PHQ-9 and we've got all sorts of other things. This may be one that you just want to kind of throw in there when you have somebody that you're kind of recognizing that there may be something going on for them. Depression is frequently tied with PTSD because depression in and of itself has some biological pieces and can be tied to traumatic events. So when we're screening somebody for depression, it may be good to also screen for traumatic events. Oftentimes we see suicide connected to both. So suicidal ideation, we know that somebody who has experienced trauma, somebody who has been diagnosed with PTSD is at higher risk for potential death by suicide. So in 2020 statistics, we're looking at suicide being the leading cause of death in certain groups. So right now, it's 12th overall when we're looking at the entire lifespan of individuals and causes of death. But for our kids 10 to 14 and our young adults or adults 25 to 34, it's actually the second leading cause of death. Third leading cause of death for our 15 to 24-year-olds, and a fourth leading cause of death for ages 35 to 44. The last statistic that I saw that I found kind of interesting considering our media coverage in this country, but suicide is actually 2 times more the number of homicides that we have in the United States. But all we hear about is the homicides, the deaths, right? We know that certain areas are really high for potential homicide, but we're not really necessarily hearing about the areas that are really high for suicide. And part of that is because of safe messaging and really talking about suicide with our individuals in our society. But that's a lot, suicide occurring 1 death every 11 minutes within our country. It's pretty scary when we think about it. And September is Suicide Awareness Month. That's part of why I'm presenting on PTSD, trauma, and suicide today, is just to bring awareness to the correlation. Just because somebody is dealing with trauma and potential PTSD related symptoms does not mean that they will be suicidal, but there is a higher likelihood of them dealing with it. A lot of studies have found that this higher level is correlated with the level of intrusive thoughts, anger, and impulsivity. So somebody who is experiencing more of the intrusive thoughts and nightmares and things like that have an even higher risk of developing suicidal ideation and potential death by suicide. What we know from a study called ACEs, and I don't know if any of you are familiar with ACEs, it was a study of about 17,000 middle-class Caucasian individuals that looked at the connections between early childhood trauma and different outcomes when it came to both physical and mental health. So if you answered yes to one of 10 questions, or I should say any of the 10 questions, then you got a score of 1 or a 1 point. And they really looked at physical, emotional, sexual abuse, neglect, both physical and emotional, and then environmental factors such as household dysfunction due to mental health or incarceration, domestic violence, substance use, and divorce. And what they found is for individuals that had identified none of these, which was about 33% of the population, their risk of a suicide attempt was 1 in 96. But as soon as they experienced 1 to 3 of these, or identified experiencing 1 to 3 of those traumas, it jumped to 1 in 10. And then 4 to 8 was 1 in 5 had a suicide attempt. So it shows you how strongly experiencing a trauma is connected to potential outcome of attempting suicide. They also found a higher risk for individuals to have heart disease, alcoholism, or other substance use, smoking, STDs. So not just trauma is at high risk for developing PTSD, but it's a high risk for developing other physical and mental health aspects. And then again, that potential for increased suicidal ideation. One of the things that has really been focused on in the last little bit is being trauma informed and providing trauma informed care across the continuum of medical and mental health care. So this is an example of one way of conceptualizing trauma informed care, looking at the 4 R's. So realizing that there is a widespread impact of trauma and understanding that there are lots of different potential pathways to recovery, and how do we get all of those different pathways available to an individual. So we're looking at realizing that there's an impact, recognizing when there has been an impact through looking at those symptoms, looking at the environmental factors, being able to respond through education and through providing resources and referrals to somebody. And then trying really hard not to re-traumatize individuals that are involved. Because once somebody has experienced a trauma, their threshold for being re-traumatized starts to decrease in and of itself. So trying not to put somebody back into an experience that might trigger some of that initial trauma itself. When we're looking at potential interventions, like I said, there are a lot of different pathways. And what's interesting is a lot of these interventions are the same when somebody is experiencing suicidal ideation. Again, not necessarily if you have been traumatized, if you've been diagnosed with PTSD, you will experience suicidal ideation. However, if you are, a lot of the interventions are going to be the same as when you're dealing with PTSD and trauma. So here's some examples. One of the big ones that we start with often is around mindfulness and grounding exercises. So this kind of graphic is an example of a grounding technique related to the 5 senses, something that people can take with them anywhere they go in order to kind of decrease the hyperarousal and the anxiety that happens with PTSD and trauma, but also can be seen when somebody is having suicidal ideation, right? They are so overwhelmed at that moment that they feel like there may not be any other options for them than to remove themselves from the environment, from the world that they're living in. And so one way that we try to get people is to be connected, to feel that they are environmentally connected as well as emotionally connected with other people. But we have to open up that window of tolerance first. And so we do that through mindfulness and grounding exercises. Um, one that I've walked people through on the phone really easily is this, 5 senses technique. Other things to look at is psychological first aid. Cognitive processing therapy, exposure therapy are often a little more specific to trauma. But as we know that the more experience in trauma that somebody has had, the likelihood of death by suicide increases. So we also want to make sure that if somebody is doing trauma treatment, that we are monitoring for suicidal ideation at the same time. Because a lot of trauma-focused treatments, we're reopening doors to past experiences, past trauma events, and it can actually increase suicidal ideation for those individuals because it becomes intolerable at times to re-experience or to revisit traumatic areas. One of the therapy modalities that I'm trained in is EMDR, so eye movement desensitization and reprocessing. Something that when I was working with individuals in therapy, I would often have to check in about, both at the beginning and the end of sessions, is, are you having thoughts about hurting yourself? Are you having thoughts about hurting others as well? Because as we worked through and processing through different parts of their trauma, things would bubble up, things would come up. And so I wanted to equip people as much as I could with some of those mindfulness grounding exercises, different resources for if and when it did happen. Accelerated resolution therapy, trauma focused CBT, these are all just different ways of seeing, oops, come out of here, Paul, ways of seeing potential intervention for somebody. So the biggest intervention that any of us can provide for somebody is just safety. Whether they're experiencing suicidal ideation or if they're just experiencing the symptoms of PTSD, we want to help them feel safe because that's going to de-escalate everything in that moment. One of the ways to do that is to have a protective environment for them. Maybe it's in the actual location that you're practicing in or that you are seeing that information or, sorry, seeing that individual person. Maybe it's in their home environment if you're doing some sort of telehealth or if you're talking to a friend. How do we create environmental safety? One of those things is counseling on access to lethal means, so that gun violence safety. Right here in the crisis department, I make everybody go through counseling on access to lethal means training. So how do we talk to somebody about access to weapons? It's, again, not political and saying like, oh, guns are bad. You need to get rid of all your guns. But hey, if you have access to an unsecured weapon, maybe we want to look at how we can decrease that access or make it a little bit safer so that you have time between when the thought occurs to when action happens. Problem with lethal means like weapons is you have a very short amount of time to intervene. Whereas if somebody were to take a bunch of pills, it takes time for that to go into effect. So we have a little bit more time to intervene. Crisis response planning safety planning with a Stanley Brown, or really anything. There's an app called My3, which is a digital safety plan that people can use. Whatever is going to work for that person in order to make sure that they are checking it and updating it and knowing that it's present for them. Coping skills, problem solving. Again, we teach those with individuals who are experiencing PTSD as well. How do we decrease the stress hormones? How do we decrease the stress response so that you're not feeling like I've got to fight the entire world around me? A lot of times with trauma and with PTSD, people become exhausted. We just physically and emotionally cannot deal with what's going on. And so we're looking for ways out. And if we can teach people coping skills and problem solving, maybe they're not going to turn to extremes like death by suicide. Now, one of the things that I want to make sure that I'm really reinforcing is this idea of they're correlated, but they're not causal. So PTSD does not cause suicidal ideation. Suicidal ideation does not necessarily directly go with PTSD. However, there are a lot of situations where people are connected. Here's just a quick example of a safety plan. This is a Stanley Brown, so it breaks it out into those 6 areas. Here's a little bit more information on lethal means. One thing that I really wanted to talk about real quickly is professional fatigue or secondary trauma, because as individuals that are working with traumatized individuals and being traumatized individuals ourselves, because we're human beings, we have to be very mindful and connected with our potential to experience secondary trauma. And that's the emotional duress that comes from hearing about other people's trauma. We're looking for a lot of the same symptoms that we are looking for in our clients, in our family members, our friends, the people that we interact with on a daily basis, that they might be experiencing trauma leading to potential PTSD. Fatigue, cynicism, irritability, reduced productivity in the work that we're doing or at home, feelings of hopelessness, anger, anxiety, even nightmares. I have had colleagues that have experienced bad dreams based on the stories that they've heard from their therapy clients, right? We are not immune to any of this. And our own trauma from past experiences can be compounded by the trauma that we are receiving, and in some ways taking on for the benefit of our clients. So we really do need to be aware of these things. And as much as I'm sure most of you have heard about the idea of self-care and how much it has been reinforced and pushed at us over and over again to the point where we're like, I get it, right? We really do need to be looking at those pieces for ourselves. This is, an idea of different ways of balancing self-care. Self-care is not easy, and that's why it gets pushed over and over and over again. But it's something very important for us to remember, and something that we need to be teaching our clients. Because again, if somebody is experiencing PTSD, we want to prevent them from getting to the point where they're so overwhelmed that they feel like there are no other options. Resources that I wanted to provide, and again, this is all information that can be found online or maybe stuff that you already know. But here in Utah, we have a lot of different options, despite them never being enough, for community-based resources. So we have Crisis Line, Recently, the National Suicide Prevention Lifeline rolled out a 3-digit number, 988, to get a hold of the local crisis line. So here in my center, we answer the crisis line for the state of Utah. You can reach us through 801-587-3000, through 988, through 1-800-273-TALK, through lots and lots of different phone numbers, or through the Safe UT app. You can also text 988 and have a conversation with a certified crisis worker or, a crisis specialist that way. We have a warm line, which is run by our certified peer specialists. They're individuals with lived experience in mental health and or substance abuse, who are there to provide support and talk through whatever's happening for individuals, to create connection for that individual. Because a lot of times when we're dealing with mental health and or suicidal ideation, there's a feeling of being disconnected. I'm the only person in a room full of people, right? We need to create connection. Mobile crisis outreach teams. Every county in the state of Utah has access to mobile crisis. It's a team that can be in person with the individual to evaluate, support, and find resources. Safe UT, again, a texting app. So it's a little bit different than 988, originally designed for our students to be able to provide not only access to crisis services, but also to a tip feature. We have receiving centers and access centers across the state. Definitely not as many as we should have and not as many as we need, but it is something that is out there as a resource that people can access. And again, you can call the crisis line to get more information or to get access to those resources for you, your family, your friends, your clients, anybody who's in need. I apologize, I ran through those a lot faster because I tend to talk way too much on different things, and did want to just say, any questions that come up, anything that maybe you're curious about, or if you would like to have a patient call while talking to you, or, we can do a conference call in order to introduce them to some of these resources. That's what we're here for at the Community Crisis Intervention Center and at the Receiving Center and the Access Center, which are different partners that Community Crisis works for. We try to conceptualize and talk through traumas and PTSD and suicidal ideation on a regular basis, but we're also here just to support people and support providers as well. So any time that there's a question of, I think this is what I'm working with, or I think this person might be a good referral over to a service that talks about trauma or grief. I didn't even touch upon grief and the fact that people can develop PTSD while working through grief of a loss. PTSD is fairly prevalent in a lot of different areas, as is those ideas about suicide. But that's all out there, and things that we need to destigmatize with the individuals that we work with or loved ones that we see all the time. Again, I apologize for running over. I appreciate everybody hanging in there with me. I can absolutely make this available to anybody who would be interested in, with all of my copious notes that are attached as well. But want to thank Jamie for inviting me to provide information and be able to talk about such an important topic as trauma and suicidal ideation.
Fantastic. Thank you, Amanda, so much. Thanks for everybody who's sticking with us. We'll still stick around to ask questions. If anybody has questions, you can go ahead and put them in the chat. Amanda, I did have a question about your resource slide. Do you have one that has all the numbers in it?
Yes.
That I can do that? Do you mind sending that to me, and then I will send it out with the completion certificates?
Absolutely.
For everybody, so they can have those, and those who registered. And I think that'll be good. And then one other question I had, sorry, is I hate seeing our kids being top in suicide. And one question I had is, and because again, sadly, my nephew's best friend committed suicide when he was 11 years old, and thinking, do they understand the finality? What steps can we take in educating our youth about, do they really understand that? Is there something that we can educate them more on, and anything specific to that?
I think when we look at the developmental stage that kids go through, that there is and there is not an understanding of finality when it comes to death by suicide. Kids are very concrete, very black or white. So I want this to end. This is what's going to make it end. I'm going to follow up on this. Not recognizing that there are a lot of other options. So being able to educate kids about resources, about options, about talking. It's so surprising when I worked on the inpatient unit, how many kids felt like they couldn't talk about their emotions and their feelings for one reason or another. It isn't all about like, oh, their parents just didn't teach them or it's a parenting issue, right? It's a lot of different mixed messages, and sometimes about not even having the vocabulary to talk about it. So this morning I was presenting to the crisis intervention training for our law enforcement, and I actually do present on mental health in children. And I always give the example of a 2-year-old, right? A 2-year-old who's having a tantrum because you wouldn't give them a candy bar, right? They're kicking, they're screaming, it's behavioral, they're angry. It's partly because they don't have a language to say, I'm disappointed, I'm frustrated. Kids don't have, and sometimes adults don't have that language to be able to talk through what's happening. So the more we can educate them on where they can find safe places to be able to talk things through and develop the skills to manage and open up that window of tolerance, and to feel like they're actually being heard is the other piece. A lot of the different death by suicide that we've seen recently because of bullying and things like that, really a lot of kids felt like, I told people about it and nothing was being done. Letting somebody know that they're heard, that their feelings are valid. Maybe we don't agree, but that's their reality in that moment, really can make a difference. And so the more education we do with kids on emotional regulation and being able to identify safe people that they can talk about and feel that they have connection, I think the better we're going to do in preventing the statistics that we're seeing. And it truly is heartbreaking to know that our little ones are suffering. So.
Very true. I did just have a comment, Shannon. This will be recorded and up on our YouTube site, our YouTube playlist, or injury prevention playlist. So anybody who registered, I'm going to send you the link to watch this again if you want it, as well as the slide that Amanda will send to me that has those resources on it that you can get. As a reminder, the Safe UT app is not just for students and community. There is a frontline workers Safe UT part of that, that us as healthcare providers can utilize. So I've got it downloaded on my phone. So I encourage everybody to use that as well.
Yeah. And know that none of these resources are for suicidal ideation specific. They're there for crisis. So if you've just had a really bad day and you've gotten home and family's bugging you and you've had a bad day at work, and it's for that too, just to say, life sucks. I don't know what to do right now.
Very true. Again, thank you, Amanda. I know we did push it a little bit over, but thank you so much for joining us today. I really appreciate it. And trust me, I'm sure I will be utilizing you again as much as I can.
Thank you so much.
Thanks everybody for joining us.
Thank you, Amanda.